Now we have a PCOS case. She's 31 years old and a female with suspicions of PCOS. She has not gotten the diagnosis officially yet. She does have certain symptoms that are suspect. So acne along her jawline and cheek. She experiences fatigue, brain fog. Her cycles are regular, but they vary between 27 to 30 days. And her actual bleeding time is about 4 days, give or take a day. And she does have normal blood sugar and A1C. Fasting blood sugar was 87. Her A1C was 4.8. I did not have a fasting insulin at the time of her initial intake. So looking at her Dutch test, she had an estrogen, progesterone, and her testosterone. You could see her E2 is on the lower end of the scale. Her progesterone also in that first third, so not very robust, and her testosterone is also pretty low. So overall, I would say her sex hormones in general are low. So keep that in mind because we're going to look at her. This is a case where we would want to really think about the adrenal HPA access piece, right? So when you see all of them are low, you should be thinking, what's her DHEA look like and what's her HPA response look like? So sure enough, her DHEA-S is pretty low. You could see that she's converting to a pretty aggressive 5A androsterone metabolite. It's actually at the very top end of the range, even though her testosterone is pretty low, right? And so that's really interesting. So I think in this case, we can't call it PCOS technically. However, you could see that the metabolites, those androgenic metabolites, particularly that DHT metabolite that is more androgenic, is really dominant, and that might be what's responsible. So by blunting that 5-alpha reductase pathway, we might actually improve some of that androgen dominant symptoms that she's experiencing. And then you could see there her estrogens are overall low. All of them, the E1 is actually below the reference range. The E2 is in the very first quintile of the reference range, and the E3 is also below the reference range. So overall estrogen levels are pretty low. And then her progesterone, you can see that she is, at least we've got one good thing going here, is that she is favoring that beta pregnadiol pathway, which is the favorable pathway when it comes to progesterone. So that's great. Androgens, again, super interesting. You could see that 5-alpha reductase activity is really dominant. Her DHEAS in general is low. So that means that we want to support DHEA production along with sulfation of DHEA, and that might be what's impacting her testosterone production. In this case, we might also want to screen her LH and FSH as well to see if there's a primary issue in terms of estrogen production, or is she just taking her testosterone and using it to make estrogen to compensate for the fact that she's not making enough estrogen. So that would be my question there. And then, of course, this could be why we're experiencing that androgenic profile. So in a classic PCOS, we're going to see a testosterone that's elevated. We're going to see increased aromatization to E1, and we would potentially want to support that aromatization with and balance it with quercetin, rutin, genistein, white peony, or licorice. We also, in this case, would want to balance that 5-alpha reductase. We can use saw palmetto, pygeum, as well as reishi and nettle root. And we can also explore other potential mechanisms to support PCOS, like licorice, chasteberry, vitex, fennel, as well as turmeric. So this was just, I feel like, a really interesting way to look at the mechanistic aspects of addressing PCOS, addressing the androgenic impact, looking at the prolactin impact, how it's impacting ovulation, addressing insulin sensitivity, as well as, again, promoting FSH and luteinizing hormone secretion. Again, these are all the various components when we look a little bit more upstream that impact PCOS. So I think it's useful to kind of put this picture together and gather all the information so that we could appropriately address it using hormones, as well as balancing her blood sugar levels if necessary. But this is what I mean was, in this case, we don't see really a picture of insulin resistance in her case, but we are seeing some of the other imbalances. So an increase in that 5-alpha reductase activity. In this case, it's not perpetuated by insulin resistance. Maybe it's an early part of the PCOS continuum, potentially. We sometimes will see a decrease in that alpha reductase activity as a result of some of those interventions are listed there. And for 5-beta reductase, again, insulin resistance and increased triglycerides are often associated with the increased beta activity. And again, PCOS shows up for both because PCOS is going to overall increase androgens. The overarching amount of androgens are elevated. You're going to see both alpha and the beta increase. So again, I can't use this as a diagnostic tool for PCOS. I think that it's an imbalance of the production and potentially because she's not producing enough estrogen. So it looks like an androgenic dominance, but it's actually a deficiency of estrogen in this case. So all her estrogens are low. Her 1B1 in particular is overactive. So you can see that the 4-OH metabolite is very heavily used versus the 16-OH, which is underutilized, and the 2-OH, which looks pretty good. So we want to really focus again on that 1B1 pathway. And we want to, similar to the first case, we want to understand why this is being upregulated, remove any of the possible triggers that are pushing this pathway this way, and we want to refocus it down the other pathway. In this case, she's not making a lot of E3. She has some E2, not a lot of E1, and in general, I would say these estrogen levels are low and probably a big contributor to some of her symptoms. In terms of her phase 2 metabolism, we want to make sure that we also support methylation and COMT. In this case, she has low methylation activity. We could consider genetic testing to see what might be specifically causing this or going on here, or we can at the very least start by doing some of that methylation adaptogen support that we talked about earlier. In terms of her organic acid testing, inflammation, and melatonin markers, actually everything looked pretty good. The only thing I would say is her melatonin was on the low end of the range. Again, just re-insinuating the fact we have to support that HPA access, but everything else actually looked pretty good. So in terms of that, at least we've got something there. So in terms of her specific intervention, we are going to start with a Mediterranean diet. That's going to help us reduce inflammation, help to balance that inflammatory response profile, and as well as improve. We can also support her with green tea or matcha, maybe have her switch out her coffee for that. In her case, time-restricted eating or intermittent fasting might be appropriate. Remember, it reduces androgenic impact in women. I really would focus in on HPA access, supporting her circadian rhythm and her sleep, really helping her incorporate a self-care and sleep routine, as well as supporting her stress response and having her incorporate meditation and breathing exercises. She loves Pilates and she works out pretty regularly, so that part wasn't hard, but we wanted to also have her incorporate a walk in the morning, especially to help support sunlight exposure in the morning, because she does express that she's the most tired and doesn't feel really recovered from her sleep, as well as incorporating grounding techniques. A summary of her interventions: we did use EPA, DHEA, as well as curcumin and anti-inflammatories, resveratrol, EGCG, very useful again for that CYP pathway as well. We really heavily focused on detoxification, particularly focusing on sulfation. Keep in mind that bile support might be indicated here, especially if they're reporting fatty floating stool. Sulfur containing foods like the cruciferous vegetables, eggs, onions, etc. And molybdenum or moly-B can also be useful for improving sulfation and that detoxification pathway in particular. We want to support lowering phase 1, particularly 1B1 pathway. So anything that might increase inflammation. She is not a smoker, but she does know a lot of smokers, and so we think it might be secondhand smoke, as well as really trying to examine her environment and start counseling her on shifting to maybe including water filter, air purifiers, changing some of her personal care products, etc., and adding in more flavonoids and resveratrol. We want to block that 5A metabolism pathway, so saw palmetto, pygeum, nettle root, reishi, EGCG, all very useful there. And then support the adrenals with adaptogens. We opted for a mushroom blend, reishi, cordyceps, and lion's mane, because it also overlaps with the cognitive function and improving concentration and performance. And that was something that she said was really impacting her at work. So we thought that was a great intervention there. So to summarize, we made it. We want to support the HPA axis, including catecholamine and cortisol production, as well as the cascade of sex hormones are intricately tied together. We want to support hormone relationships, including looking at metabolic function like insulin and thyroid. We want to address hormonal imbalances. Assessing metabolites really helps us to understand and get a more robust picture when it comes to what is happening for hormone balance, including a surrogate for detoxification. By combining what we know about serum testing along with urine and saliva, we really get a very comprehensive laboratory assessment. Your management to the approach should consider all the factors that includes inflammation, oxidative stress, environmental toxins, including exposure to xenoestrogens. We really need to focus in on metabolic function because it's very tightly tied to hormonal function. And we want to look at all the various lifestyle factors that are implicated in those mechanisms. And there's a long list of nutrients, herbs that could be useful for targeting strategy, but you did notice that there is some overlap in terms of some of those interventions. And so I would say that when in doubt, I would lean on those common mechanisms, but if you can, test and don't guess.